Thorax, Latin chest, forms the upper part of the trunk of the body. It not only permits boarding and lodging of the thoracic viscera, but also provides necessary shelter to some of the abdominal viscera. The trunk of the body is divided by the diaphragm into an upper part, called the thorax, and a lower part, called the abdomen. The thorax is supported by a skeletal framework, thoracic cage. The thoracic cavity contains the principal organs of respiration, the lungs, and of circulation, the heart, both of which are vital for life. Surface landmarks of thorax. Bony landmarks. 1. Suprasternal or jugular notch, Fig 12.1. It is felt just above the superior border of the manubrium between the sternal ends of the clavicles. It lies at the level of the lower border of the body of the second thoracic vertebra. The trachea can be palpated in this notch. 2. Sternal angle, angle of Lewis. It is felt as a transverse ridge about 5 cm below the suprasternal notch. It marks the manubriosternal joint, and lies at the level of the second costal cartilage anteriorly, and the disc between the fourth and fifth thoracic vertebrae posteriorly. This is an important landmark of the following reasons. The ribs are counted from this level downwards. There is no other reliable point, anteriorly, from which the ribs may be counted. The second costal cartilage and second rib lie at the level of the sternal angle or angle of Lewis, French physician 1787-1872. The ribs are counted from here by tracing the finger downwards and laterally, because the lower costal cartilages are crowded and the anterior parts of the intercostal spaces are very narrow. It marks the plane which separates the superior mediastinum from the inferior mediastinum. See the ascending aorta at this level. The arch of the aorta begins and also ends at this level. E. The descending aorta begins at this level. F. The trachea divide into 2 principal bronchi. The azygous vein arches over the root of the right lung and opens into the superior varia cava. The pulmonary trunk divides into 2 pulmonary arteries just below this level. The thoracic duct crosses from the right to the left side at the level of the 5th thoracic vertebra and reaches the left side at the level of the sternal angle. J. It marks the upper limit of the base of the heart. The cardiac plexuses are situated at the same level. Ziphosternal joint, the costal margin on each side is formed by the 7th to 10th costal infrasternal or subcostal angle. Dash. The xiphoid, Greek sword, process lies in the floor of the epigastric fossa. At the apex of the angle, the ziphosternal joint may be felt as a short transverse ridge. It lies at the level of the upper border of the 9th thoracic vertebra, Fig 12.1. Cartilages, the second costal, Latin RIH, cartilage is attached to the sternal angle. The 7th cartilage bounds the upper part of the infrasternal angle. The lateral border of the rectus abdominis or the linea semilunaris joint the costal margin at the tip of the 9th costal cartilage. The 10th costal cartilage forms, the scapula overlays the 2nd to 7th ribs on the posterolateral aspect of the chest wall. The 10th rib is the lowest point, lies at the level of the 3rd lumbar vertebra. Though the 11th rib is longer than the 12th, both of them are confined to the back and are not seen from the front, Fig 12.2. 3. Thoracic vertebral spittle, the first prominent spine felt at the lower part of the back of the neck is that of the 7th cervical vertebra or vertebra prominens. Below this spine, all the thoracic spines can be palpated along the posterior median line, Fig 12.3. The 3rd thoracic spine lies at the level of the roots of the spines of the scapulae. The 7th thoracic spine lies at the level of the inferior angles of the scapulae. Soft tissue landmarks. 1. The nippile, the position of the nipple varies considerably in females, but in males it usually lies in the 4th intercostal space about 10 cm from the mid-sternal line, Fig 12.4. 2. Hallux tent, it is a visible and palpable cardiac impulse in the left 5th intercostal space 9 cm from the mid-sternal line, or medial to the mid-clavicular line. Trachea, it is palpable in the suprasternal notch midway between the 2 clavicles 1 midclavicular or lateral vertical or mammary plane, it is a vertical plane passing through the midinguinal point, the tip of the 9th costal cartilage and middle of clavicle, Fig 12.5. 2 mid-axillary line, it passes vertically between the two folds of the axilla, Fig 12.5. 1 scapular line, it passes vertically along the inferior angle of the scapula. 2 The skeleton of thorax is also known as the thoracic cage. It is an osteocartilaginous, elastic cage which is primarily designed for increasing and decreasing the intrathoracic pressure, so that air is sucked into the lungs during inspiration and expelled during expiration. 3 Formation. 4 Anteriorly by the sternum, Greek chest. 5 Posteriorly by the 12 thoracic vertebrae and the intervening intervertebral discs. 6 On each side by 12 ribs with their cartilages. 7 Each rib articulates posteriorly with the vertebral column. Anteriorly, only the upper 7 ribs articulate with the sternum through their cartilages, and these are called true or vertebrosternal ribs. 8 The costal cartilages of the next 3 ribs, i.e. the 8th, 9th, and 10th end by joining the next higher costal cartilage. These ribs are, therefore, known as vertebracondylar ribs. The costal cartilages of the 7th, 8th, 9th, and 10th ribs form the sloping costal margin. 9 The anterior ends of the 11th and 12th ribs are free, these are called coating or vertebral ribs. The vertebracondylar and vertebral ribs, i.e. the last 5 ribs, are also called false ribs because they do not articulate with the sternum. 10 The costovertebral, transverse, manubriosternal and chondrosternal joints permit movements of the thoracic cage during breathing. The chest wall of the child is highly elastic, and fractures or the ribs are, therefore, rare. In adults, the ribs may be fractured by direct or indirect violence, Fig 12.6. In indirect violence, like crush injury, the rib fractures at its weakest point located at the angle. The upper 2 ribs which are protected by the clavicle, and the lower 2 ribs which are free to swing are least commonly injured. Shape. The thorax resemble a truncated co which is narrow above and broad below. The narrow upper end continues with the root of the neck, from which it is partly separated by the suprapleural membrane or Simpson's fascia. The broad or lower end is almost completely separated from the diaphragm, which is deeply concave downwards. The thoracic cavity is actually much smaller than what it appears to, because the narrow upper part appears broad due to the shoulder and the lower part is greatly encroached by the abdominal cavity due to the upward convexity of diaphragm. In transverse section, the thorax is reniform, bean-shaped, or kidney-shaped. The transverse diameter is greater than the anteroposterior diameter. However, in infants below the age of 2 years, it is circular. In quadrupeds, the anteroposterior diameter is greater than the transverse, as shown in Fig 12.8. In infants, the ribs are horizontal, and as a result the respiration is purely abdominal, by the action of the diaphragm. In adults the thorax is oval. The ribs are oblique and their movements alternately increase and decrease the diameters of the thorax. This results in the drawing in of air into the thorax called inspiration, and its expulsion is called expiration. This is called thoracic respiration. In the adult, we, therefore, have both abdominal and thoracic respiration. Clinical anatomy. Diaphragm descends during inspiration to increase the vertical diameter of thoracic cage. Hiccups. These occur due to spasmodic involuntary contractions of the diaphragm accompanied by closed glottis. These usually occur due to gastric irritation. Hiccups may also be due to phrenic nerve irritation, uremia, or hysteria. Superior inlet of thorax. The narrow upper end of the thorax, which is continuous with the neck, is called the inlet of the thorax, Fig 12.9. It is kidney-shaped. Its transverse diameter is 10-12.5 cm. The anteroposterior diameter is about 5 cm. Boundaries: anteriorly, upper border of the manubrium sterni. Posteriorly, superior surface of the body of the first thoracic vertebra. On each side, first rib with its cartilage. The plane of the inlet is directed downwards and forwards with an obliquity of about 45 degrees. The anterior part of the inlet lies 3.7 cm below the posterior part, so that the upper border of the manubrium sterni lies at the level of the upper border of the third thoracic vertebra. Partition at the inlet of thorax. The partition is in two halves, right and left, with a cleft in between. Each half is covered by a fascia, known as Simpson's fascia or suprapleural membrane. It partly separates the thorax from the neck. The membrane is triangular in shape. Its apex is attached to the tip of the transverse process of the seventh cervical vertebra and the base to the inner border of the first rib and its cartilage. Morphologically, Simpson's fascia is regarded as the flattened tendon of the scalenus minimus, pluralis, muscle. It is thus formed by scalenus minimus and endothoracic fascia. Functionally, it provides rigidity to the thoracic inlet, so that the root of the neck is not puffed up and down during respiration. The inferior surface of the membrane is fused to the cervical pleura, beneath which lies the apex of the lung. Its superior surface is related to the subclavian vessels and other structures at the root of the neck, Figs 12.10 and 12.11a and b. Structures passing through the inlet of thorax. Viscera. Trachea, esophagus, apices of the lungs with pleura, remains of the thymus. Figure 12.12 depicts the structures passing through the inlet of the thorax. Brachiocephalic artery on right side. Left common carotid artery and the left subclavian artery on the left side. Right and left brachiocephalic veins, blood vessels. 1 right and left internal thoracic arteries. 2 rear and left superior intercostal arteries. 3 right and left first posterior intercostals veins. Inferior thyroid veins. Nerves. 1 right and left phrenic nerves. 2 right and left vagus nerves. 3 right and left sympathetic trunk. 3 right and left first thoracic nerves as they ascend across the first rib to join the brachial plexus. Muscles. Stemohyoid, sternothyroid, and longus colli. A cervical rib is a rib attached to vertebra C7. It occurs in about 0.5% of subjects, Fig 12.13. Such a rib may exert traction on the lower trunk of the brachial plexus, which arches over a cervical rib. Such a person complains of paresthesia or abnormal sensations along the ulnar border of the forearm, and wasting of the small muscles of the hand supplied by segment T1, Fig 12.14. Vascular changes may also occur. In coarctation or narrowing of the aorta, the posterior intercostals arteries get enlarged greatly to provide a collateral circulation. Pressure of the enlarged arteries produce characteristic notching on the ribs. Especially in the posterior part. Thoracic inlet syndrome. 2 structures arch over the first rib, the subclavian artery and first thoracic nerve. These structures may be pulled or pressed by a cervical rib or by variations in the insertion of the scalenus anterior. The symptoms may, therefore, be vascular, neural, or both. The inferior aperture is the broad end of the thorax which surrounds the upper part of the abdominal cavity, but is separated from it by the diaphragm, Greek a cross fence. Boundaries. Anteriorly, infrasternal angle between the 2 costal margins. Posteriorly, inferior surface of the body of the 12th thoracic vertebra. On each side, costal margin formed by the cartilages of 7th to 12th ribs. Diaphragm ot the outlet of thorax. The outlet is closed by a large musculotendinous partition, called the diaphragm, the thoraco-abdominal diaphragm, which separates the thorax from the abdomen. Structures passing through the diaphragm. There are 3 large and several small openings in the diaphragm which allow passage to structures from thorax to abdomen or vice versa, Fig 12.16. Large these are vena caval opening in the central tendon, osphageal opening in the right aorus of diaphragm, and aortic opening behind the median arcuate ligament. The structures passing through large openings are put in Table 12.1. Small openings. Superior epigastric artery passes in space of Larry present between slip of xiphoid process and 7th costal cartilaginous slip of the diaphragm. When foramen is enlarged, it is known as foramen of Morgagni. Musculophrenic artery perforates diaphragm at the level of 9th costal cartilage. Lower 5 intercostal vessels and nerves pass between costal origins of diaphragm and transversus abdominis. Subcostal vessels and nerves pass behind lateral arcuate ligament. Sympathetic trunk passes behind medial arcuate ligament. Greater and lesser splanchnic nerves pierce each crus. Left phrenic nerve pierces left cupula. Thoracic cavity houses a single heart with pericardium, 2 lungs with pleurae, blood vessels, nerves, and lymphatics. Rib may be present in relation to cervical 7 and lumbar 1 vertebrae. The cervical rib may give symptoms. Ribs are weak at their angles and are vulnerable to injury at that area. Apex beat lies below and medial to the normally placed left nipple. Second costal cartilage at the manubriosternal angle is extremely important landmark. The second intercostal space lies below this cartilage and is used for counting the intercostal spaces for the position of heart, lungs, and liver. 1-7 ribs with costal cartilages reach the sternum. Costal cartilages of 8-10 ribs form the costal margin, while 11th and 12th ribs do not reach the front at all.